educating patients as to how the system actually works. And if patients actually knew how the system worked, I think it would help to become a bit more efficient. Oh, hi, Selena. Oh my goodness, look at her pigtails. So yeah. Okay, so I'll just give you like a brief rundown, and then yeah, we can go from there. You guys don't have to ask me about, questions about how medical clinics work. You can ask me medical questions if you want after. It's totally up to you guys. But just so that people are aware, the way family clinics work, it's actually quite complicated because there's different models. But I'll just kind of, and I don't know the ins and outs of every single model, but I'll give you the basics for most models and how they work. A number of years ago, there was a big reform to primary care. So, when we were growing up, it was all fee for service, meaning a doctor had a clinic, ran a clinic, and the doctor would charge OHIP for every visit. So every time a patient came in, the doctor would charge OHIP a fee. And that's how it worked. So obviously, the more patients you saw, the more beneficial it was, because that's how you made your income. So seeing upwards of, and I'm talking like those, the older, probably more like Piero's physician, right? That 75, that male physician now who's in his 70s. At that time, those guys were working, seeing 40, 50 patients a day, because it was volume, right? Volume meant income. So then what happened was there was a big reform, because we started to realize that, look, patients need after hours care. Emergency rooms were getting backlogged. So how can we accommodate patients' needs in a better, more efficient way and take some pressure off the emergency departments? So then out came the primary care models, and there's a bunch of them. So you've probably, I don't know, maybe you haven't either heard of the terms or you've seen signs in your family doctor's offices, but essentially now there's different models that family physicians can be a part of. The fee-for-service model that I just described still exists, but definitely not, that's not the majority of how family physicians work anymore. So most physicians now will be part of a group. They're called family health organizations, or FOs for short, or family health groups, which is shortened. The short form for that is called a FIG. There's CCM models. So personally, I'm in a FO, a family health organization. And the long story short is that basically the government has set out certain rules that you have to comply by if you want to become one of these groups and work as a group. You have to have like a minimum number of physicians in the group, but you also have to provide a minimum number of after hours care, which is defined as after 5 o'clock. And the reason they did this was because it removed the fee-for-service model. So we are not billed per visit anymore. I'll get into a little bit of that in a bit more detail. The way we are paid now is more of a salary. Okay, so I get paid a certain number of dollars per patient I have per year. Okay, and that will depend on the patient demographic. So we get paid a certain amount of money per year for patients that are, let's say, aged 0 to, I don't actually even know the cutoff specifically, but let's say something like 0 to 15 years old. Then I get paid a different amount for patients, let's say, aged 15 to 35 or 50 years old, and then older patients are different. And the reason for that is because I will get paid a little bit more per year for more medically complex patients, which is generally the older patients, because they take up a lot more time and they're more medically complex. So what that does is a couple of things, right? It takes a little bit of pressure off of the physician, because now I don't have to see 50 patients a day if I'm trying to support my family and make an income, right? It gives me it takes a little bit of pressure off of me, but it also allows me to spend more time with my patients, because if I don't have to see 50 patients a day, I can spend 25 minutes with a patient and not be worried about it eating too much of my time during the day. So generally speaking, most family physicians will book 15 minutes per patient, but it also gives us the freedom now to say, look, I know that this patient is coming in with mental health concerns. I'm going to book a half an hour appointment for that patient every single time I see them, because I know that I end up spending more time with that patient. And it takes a bit of pressure off of me from a financial point of view. So that being said, then what happens is every time I see a patient, that little bit of fee for service still kind of exists, meaning that I'll tell you that, so for a basic, and we bill based on codes, okay? So if I'm just seeing a patient for a regular 15-minute appointment, like let's say it's a blood pressure check and I listen to their heart and their lungs and I make sure everything is fine, I'm gonna bill, if I was a fee for service doctor, I would be billing about $33 for that visit, okay? Now I'm not fee for service, I'm a family health organization. So the $33 kind of goes out the window because I'm already being paid for that patient for that year. However, we do what's called a shadow bill. So for every patient that I see, I still bill the visit, but I get paid 10% of that visit, okay? So I'm essentially being paid like $3 and let's say 40 cents for easy math for every patient that I'm seeing, okay? And then if you want to get into real details, which is not really important, I don't think so much for you guys, but there are certain premiums that we're allowed to bill. So if I'm doing mental health counseling, if I'm taking care of a patient with congestive heart failure, if I have to manage somebody's blood thinner, okay, I can get paid premiums based on that because it's extra work and it requires a bit more care. So the caveat to that was, okay, we're going to pay you now on a salary basis, right? Which is nicer for us because it gives us a bit more income stability. It's not so, it's more predictable, right? I have a general sense as to how much I'm going to get paid based on how big my roster size is. So that's the other thing. What's a roster? You might have had to sign forms. Has anybody had to sign a form when you're in your doctor's office and you're like, what the heck am I signing? Has anybody had to do that? Okay, so basically what you're doing there is you're signing yourself up as a patient to that physician. So you are on their roster, okay? So a typical roster size really varies. Okay, so I myself probably have about 800 patients on my roster. So I take care of those 800 patients. My partner has a very large practice. She's probably more around the 14 to 1500 patient mark. My other partner has a much smaller practice because she has 2 little kids. So there really isn't a cap as to how many patients you can roster. For me, I based it more on the fact that I work 3.5 days a week and I don't want my patients waiting too long to have to see me. Okay, so I'd like to see my patients within a week if possible. And if I have a 1,500 patient roster, that's gonna be a lot harder to do. But going back to what I was saying before, the caveat for that was, okay, we're going to pay you guys based on a salary. So there's a lot of benefits for that. However, you have to provide after hours care. Okay. And that's where the models come in. So for a family health organization, which I'm part of, my group is very small. We're 3 physicians who physically work in the same office. We don't have to be working in the same location. We just have to have access to records. But what that means is that we are required, up to a 4-person family health organization, we're required to provide that many days of after hours care. So we're a 3-person full. That means we have to provide 3 days of the week where we are providing after hours care after 5 o'clock for a minimum of a 3-hour block. Okay, so we have 3 days a week in my office where patients can access us after hours. So for example, I always do a Wednesday evening clinic. Okay, so my Wednesdays, I work 2 until 8. 2 until 4, I'm working regular, like I see my patients regularly. And then my 5 until 8 is my evening clinic. Those evening clinics are open to all 3 practices. So that's the benefit for patients. I have my own roster of 800 patients and I see specifically my patients during regular office hours. I can also cover for my, like, let's say one of my partners is on vacation, then we can certainly cover for each other. But the evening hours are open for all 3 practices. Okay, so during that evening clinic, I'm seeing patients from my roster. I'm seeing patients from my 2 partners' rosters as well. Why do we do that? Because we don't want patients going to walk-in clinics. And why don't we want them going to walk-in clinics? Because we have your records. So it's a lot more effective. It's a lot better primary care if I can see patients that I have direct access to their health information. Okay, it's a lot better for patients because they have physicians who have their records. We have their medical history on file. And so that's the benefit of a walk-in clinic. So now what happens? Has anybody ever gotten a phone call or a letter or a note from their doctor saying, or have you ever seen the signs in your doctor's office saying, please do not go to walk-in clinics before you call us? Have you guys seen those posters in your family doctor's offices? Okay. So the reason is because we are trying our best to keep patients out of walk-in clinics, right? For those reasons. From a financial point of view, what happens is as a family health organization, we have a theoretical pool of money that we get to, okay, the three of us in my office, for example, and that will be paid to us if we meet a certain number of patients that have not gone to walk-in clinics. Do you see what I mean? So let's say we have had very minimal visits from our own patients to walk-in clinics, and the government, because every time a patient is seen at a walk-in clinic, that's recorded, right, through OHIP. So the government gets those visits, and they say, okay, you guys have had way too much outside use. Your patients have gone to walk-in clinics too many times, so we do not meet criteria to get that access care bonus. It's called an access care bonus. I can personally tell you that my office has never gotten that bonus. Okay, so we have never gotten that extra money because we have a very high outside use, which I'll get to in a minute. So that's why it's for two reasons, right? Yeah, financially, we would like to get that access care bonus if possible. I mean, we're making, we're working, but also it's because we are trying our best to keep patients out of walk-in clinics for the reasons that I mentioned before. So that's generally how a family health organization or a family health group works. Again, there's subtle differences between the groups, which we don't have to get into, but it basically, like, there's a bunch of different things, right? So some groups have access, they can hire like nurse practitioners and dietitians and pharmacists as part of their team, which is obviously very beneficial to a patient. We don't have those services, but again, it depends. It depends on the size of the group. It depends on what kind of group model you are working in, and that kind of thing. So walk-in clinics. Walk-in clinics definitely have a role, okay? And the reason walk-in clinics were developed is because I mean, not me personally, but obviously the government was trying to reduce emerge backlog. Where it becomes a problem is when we have patients who are going to walk-in clinics for things that are not urgent, okay? Or things that can wait a day or 2 days to see your family doctor. So it becomes a bit of an issue. I can personally tell you, I've seen many times patients who have gone to a walk-in clinic in the morning and they will come to see me in the afternoon to make sure that the walk-in clinic physician was correct. Okay, that is an absolute misuse of a walk-in clinic. Secondly, which I'm just mentioning for the sake of mentioning, if a family physician or a primary care physician has seen that patient in the morning and has billed that visit, when I see that patient, I cannot bill for that visit, okay? The government will not pay me. So I do not get paid for that visit, even though I will see the patient, okay? My advice to patients is if you're gonna go to a walk-in clinic and you don't trust that physician, you shouldn't be going, okay? My other beef with this sometimes is walk-in physicians are physicians. They have undergone medical training. A lot of them are emerge physicians. A lot of them are family doctors. Those are the two types of doctors that generally work in a walk-in clinic. They are physicians. There is no need to not trust them. That being said, walk-in medical care is certainly not ideal, okay? I'm not a walk-in physician. I can imagine that part of the reason is because they're trying to get through a huge volume of people in a short amount of time. I know that there are stories where walk-in physicians will hand out prescriptions without, an adequate examination. They're under time pressure. A lot of the times it's because those physicians doing the assessments are emerge physicians. So to an emergency physician, right? If you're not an emergency, it is they see things as, is this emergent or not emergent? If it's not emergent, I'm going to get this patient out because I see that they're stable, right? They see things from a little bit of a different point of view than family physicians would. We typically would spend a little bit more time counseling and educating and that kind of thing. So it also, you have to keep in mind, what that physician is kind of coming in with depending on their background. So my point here is they definitely have a role, especially for, like, for example, my patients on a Tuesday night, they have no access to us. So if something comes up that they're worried about, let's say they wake up and they have symptoms of a urinary tract infection, their kid has a fever, they're having some shortness of breath and they have a history of asthma. Should they be going to a walk-in clinic? Absolutely. That is an ideal use of walk-in medicine because you don't have access to anybody else, yet it's not emergent enough to go to an emergency department. Emergency departments are for emergencies. They are not for ear pain that's been there for 2 days. okay? They are not there for pregnancy tests, okay, which I have seen by the same patient twice. Even after I did a full educational session on why that was an inappropriate use of the emergency department, and it happened again. And I'm telling you this just from a physician's point of view, because, you know, having worked as a physician for 13 years, I think I'm getting to the point now where I'm a little bit less tolerant of some of this stuff. And it's not because I've become mean, it's just because I've seen the abuse of the system. And when you look at our system compared to the system, for example, in the US, right, we should be so grateful and so thankful that we have what we have, and yet we abuse it because we don't have to pay for any of it. You know, and I tell patients, if you had to pay $10, just $10 to go to the emergency room, you would think twice about going because you have ear pain for a day, right? We pride ourselves in Canada, the fact that we have free healthcare, right? Universal healthcare. And I think it's a great system. And I, you know, personally, I don't ever want to see us not have that, but it comes at a bit of a cost sometimes. So, so yeah, I think that's basically just the gist as to how we work. The other thing too is, you know, I don't think that our representation does a great job either at reminding people in the public that we are businesses, right? We are small businesses. I run a medical clinic. I am running a business. I have a family to support. You know, I think there's become a little bit of a misconception in the last few years. I've seen it more. It's like, you know, people in healthcare in general, it's not just doctors, but I almost feel sometimes like, and I'm not, you know, I don't like to sound like a spoiled brat, but it's almost like, well, we have to be martyrs, you know? And I to be honest, I even see it within physicians sometimes. Like with this whole COVID thing, for example, right? I see physicians kind of bullying other physicians, right? Well, we should be offering our services to, you know, hospital emergencies and ICUs and that kind of stuff. Well, look, I went into medicine because I want to help people, no, but not because I want to harm myself or bring harm to my family, right? I'm comfortable doing what I'm comfortable doing, what I was trained for. You know, I should not be expected or bullied into doing something else. So, but I think that sometimes it's like, okay, let's just sit back and hold on a second, right? Or when I have people complain about our hours, you know, I'm very upfront. These are my hours when I have a new patient. If these hours work for you, great. If they don't work for you, then that's okay. But you have to find a physician where their hours are going to work for you. You know, I work 3.5 days because I have kids. I have to run my household. I have to make an income. And, you know, when the government, you know, makes blanket statements like the average family physician income is $300,000 a year, I want to reach my hands through the phone or the TV and shake them. I don't know too many physicians who average $300,000 to $500,000 a year. Is there discrepancies between medical professionals and specialties? Absolutely. Is some of it maybe a little bit unfair and overpaid? Probably. But let's not forget what they do, right? How many people can fix your eyesight? How many people can take your cancer away? How many people can diagnose your, you know, your heart disease, right? What's the equipment that they're using and how much does that cost? So when the government starts to tell us that we're going to be penalized for ordering an MRI that wasn't necessary for back pain, that's very insulting, okay? Because there aren't too many other professions where the government dictates what we order, right? We went to school to decide who needs an MRI and who doesn't. Luckily, that never went through, but that was just an example of one of the things that they say that they've threatened us in the past, right? If you guys are ordering too many MRIs that are unnecessary for low back pain, it's going to come out of your income. You know, the government does not publicize the fact that, you know, our pay was retroactively cut a couple of years ago, right? They went back months. And now with the whole COVID thing, I don't know, some people maybe saw my posts. So now what's happening is because we've been turned upside down, right? We are not seeing patients in person if we don't absolutely have to right now because of COVID. So anybody who calls my office with a fever, a cough, any kind of COVID symptom, we do not see in person because we're not properly equipped. But that being said, we're doing a lot of stuff by phone. So the government implemented phone codes, okay, which are different than our regular codes that we would bill. They're a little bit less because we're not doing inpatient care, which is understandable. But then we were told 2 weeks ago that these codes are not going to be paid or submitted or billed to us probably until July. Well, we've been working like this since March the 14th. So there are physicians, think of the fee-for-service physicians who are working now since March 14th and not going to be paid till July. Would any other profession accept that? I mean, it's right, but we're doctors. So we should just keep our mouth shut because people need us. And that's just the way the cookie crumbles. It looks like that's not going to be the case. The OMA has been doing a lot of advocating on our behalf. And I just got an email this morning that I think says that we're probably going to be getting those billings as of May the 5th. But I'm just shedding light on the things that I feel like our professional associations do not do a good job of educating the public about. And I think it's a little bit unfair. But that being said, most of what I wanted to just kind of explain was how clinics work, what the walk-ins are really for and what Emerge is really for. Because I know people complain, right? Like, I had to sit in Emerge for 8 hours and it's like, it's awful. I've had that experience before and it sucks. But the reason you're sitting there for 8 hours is because the two physicians, usually an emergency room has 2 staffed physicians at a time, they are having to weed through the person with, a UTI, the person with a fever and a cough, the person with an earache, right? They have to weed through those patients. They have to see them, and they're taking up hours and hours and hours of time. So I'm just trying to give a little bit of a behind the scenes look so that, you know what it's like. Now, that being said, should you question if you should go to Emerge or not? If you're having symptoms that you don't think is normal and that are scaring you, I always tell my patients, always ask, always seek medical attention. Your job is not to figure out, if you are, what your diagnosis is. Okay. That is not your job as a patient. But, if it's something you've had before, if it's something that you've been living with, let's say for 2 weeks and really hasn't gotten any worse, but you're just tired of waiting it out, those are the things that should be, should not be seen in Emerge.
I know from our experience that we've called telehealth, especially when we have kids, like brand new kids, newborn kids. Every time we call, it doesn't matter what it is. It's like, you should go to the Emerge.
Yeah.
You should go to the Emerge. Do you think that's kind of like, also wrong? Cause I don't know. I guess it's a shitty situation because if they don't tell you to do the right thing, they're probably gonna be held liable somehow, and then we'll probably end up suing them. So really, when in doubt, just go to the Emerge. So when you hear go to the Emerge, it's like, again, say like, you're hypersensitive as a new parent, and you don't think, like, you just don't know. So it could be something so small and so, like, we'll say like insignificant that should not, take up tax money and go to the Emerge and all that stuff. But they'll be like, go to the Emerge, and then you go like, oh yeah, it was like something so insignificant. It's like, it could have waited and gone to the family doctor the next day.
Exactly.
But I know that every time they say, like, they're like, go to the Emerge, so you just assume that, like, don't even, like, just bypass everything, and you want, quote unquote, no disrespect, like, you want to go to the real doctor and go to the real place where they have the real tools, just go to the Emerge, right? So I guess that's
you're a parent of a newborn, then it has to be sick kids. You can't go anywhere else. It has to be sick kids, right? Like,
yeah, absolutely.
But so as far as I know, telehealth is basically, there's staff that are working off of an algorithm, right? So you're going to get 2 pieces of advice from telehealth. You're either going to be told to go to Emerge, or you're going to be told to follow up with your family doctor in 24 to 48 hours, right? Because a lot of times we get the telehealth, the phone calls, we get the printouts of them. It is not an ideal system. I hardly ever, we have telehealth even on our answering machine at my office. Just because, if there was a case where somebody really didn't know and they wouldn't think, well, maybe I'll just go to Emerge. I guess but it is a very, how can I put this nicely? It is not a very helpful system.
Yeah. And it just reinforces that, like, it's, skipping, levels where it'd be like, say it was on, like, I think it was on a long weekend one time, and like, we could have waited to go, an extra day and go to our family physician. But we ended up going to the walk-in clinic instead. Right. And then you realize, again, I think I don't know if it was my daughter or I don't know, was it Cristiano or Selena, like, misdiagnosed, and we didn't know until we waited like a week later and realized, like, it's actually getting worse. There's something wrong with her skin. I can't remember what it was, but it was caused by something. And we went to our family doctor, and they're like, oh no, actually this is what it is. And it was like, shit, if we just waited a day and kind of relaxed and realized, like, this who actually knows us, we have a relationship with us, with them. And we should just not be so super emotional and just, be reflexive.
Yeah, and I think for me, I have probably the most tolerance and the softest spot for new parents or for parents of little kids, right? Because when it's your kid, obviously there's a lot of emotion attached to that. So, I'll have parents who will say to me like, well, I took them to Emerge because I just didn't know what else to do. And they're almost apologetic about it. And I say, look if you know your kid, the bottom line is parents know their kids more than anybody else. And if you suspect that there's something wrong and you're worried about that child, you take them to Emerge. Like that's the kind of stuff that, I'll tell people worst case scenario. Yeah, it's something that could have waited, but did you know that as a patient? That's why I'm saying it's not your job to necessarily diagnose something or to be able to even triage something, right? I mean, but that being said, right, I'm talking more about like I said, like adults who, they've had cold symptoms for a day, right? Runny nose, but bit of a cough, sore throat since yesterday, right? You don't need to be seen in a walk-in clinic that night, right? If you're otherwise well and you're having just upper respiratory tract infections symptoms. So, I think that's new parents especially get a lot of leeway when it comes to stuff like that, right? And it's, it's funny because now during COVID, I don't know if you guys have been seeing on the news and headlines, but we're seeing cases of emergency situations, specific heart attacks that people have been having and dying from on the rise because they're so afraid to go to Emerge. So it's like there's this like huge imbalance, if you're having symptoms of a heart attack right now, you better go to Emerge, COVID or no COVID, right? Because those things are still happening. You're still going to have heart attacks. You're still going to have cancers. You're still going to have asthma attacks that need to be treated in the emergency department. So it's
Doriana,
common sense. Mm-hmm.
Just a funny thing about that too. So my brother's a paramedic, and he was saying how now he's getting less calls than like ever because people like the calls that he's getting are people are just like they're just dying at home.
Yeah.
Nobody wants to call 911 because everyone's terrified to go to the hospital.
Yeah.
He's going to people's homes that like died of heart attacks and like nothing COVID related, but people are just dying in their home because no one wants to call 911. And he's had like, I think the other day, I think he had like 2 calls in one day where normally he would have like 7 or 8 or more. So it's really interesting that you brought that up too.
Yeah, it's happening. And I mean, I think that this is teaching people a couple of things. Number one, I think it'll be, in a way, I almost think it's like one of those blessings in disguises. So even us, right? Like I've seen a huge drop off in phone calls, even from my own patients. So part of that is like people are realizing that they don't have to see their family doctor for every single little thing, right? Which is good because again, if you're waiting 2 weeks to see me, I'm probably seeing a lot of things that don't need to be seen right away. So I think people will come to that understanding and be like, okay, probably what I would have sort of, run to my family doctor with before is not as important as I thought it was. But again, you have to be conscientious of that, right? And the flip side is, are you ignoring something that could potentially be really serious because you're just too afraid, right? So yeah, so that was the big kind of uproar last week, was that a lot of physicians are seriously having to look at closing their practices, right? Because if we're not going to be paid till July, especially those fee-for-service physicians, it's a business, right? We have staff to pay, we have overhead to pay, we have supplies to buy. Can't do that if you're not making any income. So hopefully that's been rectified according to the email I got this morning, but we'll see. So yeah,
I think there's such like, I appreciate you talking about this because I think there's such a huge misconception about doctors and just there's so much assumption about what they think about you because again they put you in like all under one term, like you all make the same income, pretty much like you guys are like salary based, you guys are not self-employed, you guys make this much money but there's no expenses or anything involved in that. And I think again it's such a huge misconception, and I don't know what it is because again, I think it's maybe like, the college doesn't talk about it enough or doesn't want, like you guys are on such a high pedestal that everyone just assumes like you guys are gods, you guys know everything and everything is like, you're getting everything in return in that same way where everything is just so secure, I guess, financially and all that, where, again, we just assume that like you guys have everything and I don't want to say it's easy. It's just like, but that's what you get when you become a doctor. You know what I mean? You know everything. All the money's just handed to you, and you get to make all your decisions because you guys are so smart. You guys have control of everything when it's not the case at all. No,
Yeah,
you know,
and I
not,
mean,
not that's not the case, but it's not that, it's not as clear as you know, people
exactly.
think it is.
Exactly. And don't get me wrong, like, am I lucky? Do I have a really stable job? Absolutely. You know, I realize that my blessings. I know how lucky I am. That being said, right, when you know, the ophthalmologist's making, you know, 5, 6, 7 times more money than me, should they be? Yeah. You know, their equipment costs, you know, probably 3 years of my salary. And you know, I have no problem being open about how I'm paid, how I, you know, financially. You know, I have a very poor business sense. Like, I am not at all business minded. But, you know, I have no problem telling people how I get paid, because I think that that's part of what people need to know. You know, so the way I work, for example, is I don't own my clinic. So I'm an associate. There's 3 of us. And so I give my, the head physician in my clinic, head meaning she runs the clinic. We all have our own independent practices, but, you know, I pay her 30% of my monthly income. That's the way it works. And that's to cover our electronic medical records, our staff, our overhead, our supplies, you know, our cleaners. So it's a business, you know, I have to think about that. Right. Could I increase my income? Absolutely. I can roster 200 more patients. But it comes at a cost, right? I'm going to have, that generates more paperwork. It generates more office hours. So for me, it's a balance. It's got to be a balance. But yeah, I appreciate the fact that, you know, surgeons go to school probably 5 years longer than I do, you know, and I'm not downplaying family medicine at all. We are the gatekeepers, right? Patients get nowhere without a family doctor. Referrals, mental health that we do, all that kind of stuff. But yeah, I think there is a gradient, right? So, you know, it kind of irks me sometimes when, exactly what you said, Chris, we're painted kind of under this light, like we're almost like we're selfish, we're greedy. You know, we work pretty damn hard. And it's a skill set that not everybody has. So I'm not saying it's perfect, absolutely not. But there's got to be a bit of a balance too, right?
Absolutely. And I think people also forget that you guys have families and you have other responsibilities outside of being a doctor or a family physician, right? And I think, yeah, like hearing you, like, well, you have kids, you got to take care of them, you got to bring them to their hockey game and their dance and their school and their whatever, and you know, while maintaining and caring for people's lives at the same time, like outside of your family. And I think it's a huge responsibility, but people I don't think they think outside of the office, because they're like, well, you're a doctor and, you know, you make this much money and everything's perfect probably for you. It's like, yeah, things are probably going well, but regardless, there's still a whole other life that people, like, I think completely block out because they just think, well, you're a doctor, and that's all they focus on.
Yeah, and I think everybody can relate to it to some degree, right? Like, even you guys, for example, let's say, you know, you're running your business, you're running your gym. Maybe people, you know, I think about it in terms of, like, you know, I probably have 10 questions, you know, a day that I feel like I can ask, but I don't know about when it comes to fitness or nutrition or stuff. But, you know, am I just going to kind of randomly email and, you know, I don't want to use the word bother, but it's like, there's boundaries, right? The boundaries have to be set. So it's like, think twice before, you know, maybe I can ask this question next time I'm at the gym. Maybe, you know, it's just the way you approach it. Like, you know, I don't want to take advantage and use up all your time, because I know that once you leave that gym, you have a family, you have things to do, you have a life to lead, you have a household to maintain. So it's just, you know, thinking about that, you know, putting the boundaries in place, trying to respect them as much as possible. And going from there. You know, that being said, the biggest part about family medicine is that you have a relationship with your patients, right? And that's one of the reasons why I chose family medicine, because I liked having that long-term relationship with them. So, I mean, I hope that most of my patients know it. And I always leave the room with the same comment. If things don't get better, or if anything changes, you call me back, right? So that's the nice thing about family medicine, is that, you know, I have this constant, you know, connection with them, and it's continuity of care, which is actually the other reason why I forgot to mention about the walk-in clinics, right? They're convenient, but it really impacts your continuity of care, meaning your family doctor has a relationship with you, right? I've known my patients now for 13 years. I know the ins and outs of their lives. So it's, you know, you don't get that when you go to a physician that you've never met before. So it's an added benefit, right?
Jordana says she feels bad for messaging you all the time now.
No,
I'm just joking.
no, and that's like, I didn't mean it that way.
Me
But
too.
no,
That's it.
no,
Well,
and
that was my next
Doriana, I have a rash. What is it? Like,
I sliced my daughter's finger open. I was like, what do I do?
honestly, like, and that's where I feel like this is from a personal perspective, this is where I feel like, you know, I get a lot of, I really do get a lot of pleasure, and I get a lot of that self-gratification knowing that I've helped somebody, especially if it's somebody who is worried. And I know there's nothing to worry about, right? Like, there isn't much of a better feeling you can get than saying, oh my God, don't worry about that with Selena or whatever, right? When you've been panicking for a day. Like, and I've always said that to my friends, especially if it's about their kids. I know it does blur boundaries a little bit, but if it's a Saturday and somebody's, you know, and I've done this before, right? One of my friend's kids has a wickedly high fever and sore throat and they think they have strep, call me, right? Like, I mean, I'm your friend. You can't do that with everybody, but it's just, it's one of those things. And there have been times when I have felt like the boundaries have been too kind of like the floodgates kind of opened, and I had to rein it in. But I think I'm pretty good at doing that. So yeah, no, I didn't mean it to be like a don't ever text me again. No. No. So. Anybody have any medical questions or other things that they wanted to ask about, or is everybody good?
I had one question. I just remembered, I wanted to bring it up on the last podcast and I just kind of forgot about it. So I was listening to a podcast a while ago with one of a top physician in the US, and the interviewer asked the doctor, is there any information, it's like, what's the inside information that doctors know that regular people don't know that you can explain really quickly? And her answer was second opinions. She said, don't be afraid to go to multiple doctors, especially over anything like more than like something mild, and ask around, because I can't remember what it was. It was obviously US stats, but it was like a terrifying amount of doctors disagreed what the issue was on whatever the given issue is. And her thing was, you know, if it's something serious, like go get 3 opinions, because the first opinion, you know, it's like randomly, like it's something like a 25% chance it could just be wrong and it may not be the issue. So I was just kind of curious if like your view was similar to that, where, you know, you should be doing that, or there should be more trust and like just follow through with somebody because it's like the relationship's most important, like just what your thoughts were on that.
So this is a great question, right? Because we see this all the time. And one of the things was that I was just going to say was, this is exactly where your relationship with your family doctor is key. Okay. Because I have patients who, you know, this happens all the time in practice. Let's say I have a patient who's gone to see an orthopedic surgeon, you know, and that orthopedic surgeon is recommending surgery, and the patient comes back, well, you know, Dr. Parkin, I don't know, should I do this? Should I not? It comes up a lot in women's health, you know, should I have a hysterectomy? Should I not have a hysterectomy? Should I get a second opinion? And the reason why I say that it's important to have a relationship with your family doctor is because there are times when even I think, you know, maybe we should get a second opinion. I'm not entirely sold on this, or I'm not entirely sure. And then there are other times when I know that the opinion and the advice that was given by that specialist is probably as good as it's going to get. And that's where, you know, people, if you have that relationship with your family doctor and your family doctor saying to you, look at Joe, like, you know, this is exactly what I was assuming the specialist was going to say and do. I feel very comfortable in this, in his decision. Then a lot of times that just puts the patient's mind at ease and says, you know what? It's almost like that is the second opinion, right? They're getting the reassurance that that is a good, you know, it's a reasonable approach. That being said, there are very few times, and again, this is very physician dependent, okay? Because it can get ridiculous, right? Like people will ask for 3 and 4 opinions about the same thing. And it's like, first of all, that does tax healthcare dollars, right? We have to pay every single physician for every single consult about the same thing. And if you're getting the same answer over and over and over again, there has to be a point in time where you just say, this is it, right? But that being said, generally speaking, I do not have a problem sending patients for a second opinion, because I want to know that, and again, it has to be reasonable. I'm not talking about things that I know for sure is cut and dry. I mean this when it's a bit of a gray area, and maybe there is something else that we haven't, you know, that hasn't been assessed or hasn't been looked at. because I want to make sure that that patient has all the information, possible that that they can have to make an informed decision. So very rarely will I deny a patient a second opinion. I just feel like most of the time, if it's not unreasonable, let's just, make sure that we've crossed the T's and dot the I's. But I think the fundamental part of that is, do you and your family doctor or the referring doctor have a good enough relationship that you can decide together, if and when, you need that second opinion. Here's a question from Patty, or a comment, sorry. The pediatric clinic I take my kids to offers a paid email service. If I have a question or concern, I can email the doctor and they'll advise if I need to bring them in or not. It saved me a lot of headaches and time, especially when my kids were young. Yes, this is a great point. And actually, that's the other thing I didn't really address. Do any of you guys pay your family doctors like an annual fee that covers things like prescription renewals, notes, stuff like that? You may not, because we're still fairly young and stuff, but the other thing that the public really doesn't know about a lot is our uninsured services, right? So if I have to do a prescription renewal for a patient, meaning the pharmacist has now sent me a letter and said, this patient is out of their medication, they need a renewal, okay? If it's something that I need to assess the patient for, let's say I'm renewing their blood pressure medication, but I haven't seen them in 6 months. I'll say to them, no, they have to come in to see me because I need to make sure that the medication is working, right? I don't have to change their dose or anything like that. But if it's medication that they're on all the time and isn't going to change, so I have to go into the patient's chart. I have to review their chart, do a quick chart review. I have to, renew the prescription, fax it off. We don't get paid for that. And I know people will say, but it takes you like 2 minutes. It does, but I might get 20 of those a day, right? My partner who has 1,500 patients might get 30 or 40 of those a day. And that's time that we are putting in after hours. Okay, so this is all after we've seen our patients. My patient encounters is probably 25 to 50% of my day. I then have to write all my notes. I have to go through all my labs, look at them. I have to, I have to renew prescriptions. I have to, send messages back to patients regarding their lab results and follow-ups and all that kind of stuff, right? That's the stuff that you don't see as patients. And so some of those things are not covered. Another one is exactly, as Patty said, it covers notes. So notes for missed work, notes for daycare, right? We don't get paid for that. And it's not because we're being greedy. It's literally we're covering our cost, right? We have to buy paper. We have to buy printers. We have to buy, printer cartridges. We have to pay our staff to do that work. So that's where you might see those extraneous costs come. So sometimes what we do is we'll offer an annual fee. For $100 for the whole year, your prescription renewals, your notes will be covered. So you don't have to pay every time you come in, kind of thing. I think my clinic charges $11 for a prescription renewal or something like that.
Doriana had a post-COVID kind of related question. She was basically just saying, like, there's some states in the East that are what they're doing. They're allowing families to see like other families, essentially. Yeah. Where it's like they're basically extending from a group of 5 to a group of 10. And if you see that other family and only that other family, like, that's okay. Do you think that that's maybe the direction that's something going to happen in Ontario sooner than later?
Yeah, I think we talked about this really briefly last week. The reports and the release that Ford gave out was pretty vague in terms of how they're going to go about lifting restrictions and stuff. But I think that that's probably the way we're going to see it initially with social distancing. I think we're going to be able to expand our family contacts. So I agree. I think it's going to be something like that where, okay, now you can extend your family bubble to one other family kind of thing, right? Or one other, again, that family has to be living in the same household, most likely. That's the way it's going to be. Yeah. But you can kind of extend your relationship with one other family and then slowly go from there. I think that's the way it's going to sort of implement, which makes sense, right?
Yeah. I mean, if you think about it too, like if it's one family in one household, really that's only one level of exposure, right? Like if that is one family unit, it's not like,
and if they've done a good job themselves of self-isolating, then yeah, exactly.
Cool.
Yeah. I know everybody's so eager to go back and to open and lift restrictions and stuff, right? But we've got to be careful. And especially with the nice weather, right? Like
I think everybody's getting really positive, seeing the nice weather and It's like,
Yeah.
oh, it's almost back to normal. Let's get outside. Let's screw it. Let's just get back to life.
I know. I'm going to do the OG WOD this morning outside, but I have to be mindful of that, right? I have to make sure that I know there's like a bunch of construction guys working across the street. So I have to stay on my side of the street. I have, you have to cross the street when you see somebody on the sidewalk. Just be mindful of that, right? So there is a way to be out there and be safe. You just have to be careful. Because there's no way I'm working out inside today. Any other questions, guys? COVID or unrelated? Everybody good? Okay, well, hopefully that sheds some light onto the actual system. I don't know. I just kind of feel like we do such a bad job of representing ourselves as physicians, and we really don't educate people very much as to how it works. Sometimes it just helps to know, right?
Yeah, thanks a lot, Doriana. You know what? Again, you answered a lot of questions that I guess I don't know if anyone else thought, but I was definitely thinking about. And yeah, you know what? Again, I think we take you guys for granted, to be honest with you. As much as we're giving you guys appreciation, but there's definitely a lot of things. I think there's a lot of assumptions, I guess, and it's because the doctors don't explain themselves well enough for whatever the reasons are. But I think it's important for everybody to know that, because it's going to humanize you guys, and people will I think have more respect for you at the end of the day, and have respect for your time, and understand that if they have respect for you guys, you're going to be able to do a better job for everybody else at the same time. So we're all going to benefit from it.
Yeah. Yeah.
You know what? It's really true. Like, I really think it's just a big perception thing. Like, as soon as you said, family doctors we're family businesses. Like, you guys are family businesses in the same way that we're a family business. And like, immediately that's like, oh, I can understand everything then. Like, I feel like, obviously not on a medical side, but like, I can understand like that it's not just, 2 minutes to do this, 2 minutes to do that. It's like, this is my time. This is my profession. This is how I pay my bills. And this is how I'm going to, essentially raise my kids on this money. So it's like, it does matter. It's not just, oh, I'm a doctor and I've got to do good. It's like, well, at the end of the day, I'm still a human trying to have a job.
Exactly. And I mean, like, not only is that, and it's like, plus, a lot of our job is very emotional, right? Like,
you guys deal with some stuff for sure.
Yeah, exactly. Right. So, when I lose a 50-year-old patient to, lung cancer, who's never smoked a day in her life, like, that weighs on you for a bit too. And it's like, okay, I have to deal with that and, pick myself back up and, just remember that, you got to kind of keep going, and you have to learn how to dissociate yourself while remembering that you have to just work, right? This is a job. So yeah.
You know what, Doriana, you made me think about something. It's like my mom picked our family doctor since we were young, right? So we've been going to the same family doctor. And I mean, I really like my doctor, but it's like you get stuck in like going to the same doctor since you were young and you're just kind of comfortable. But for me, like when I first met Chris, I'm like, like I'm going for my annual physical, and my mom was very adamant on going like every year. She books our physical every year ahead of time. She's like, this is the day you're all going. And we're always like, oh my God. But that's ingrained in my head now, where it's like, oh, I haven't gotten a physical, now that I'm married and she doesn't book it for me anymore. But what I'm trying to get at is like, if you're not.
Okay, I'll take my physical. Is that what you're getting at?
I'm getting at your physical. He's like, oh, I haven't got a physical in so long. And I'm like, you don't go every year? Like, what do you mean?
And Natalie Patrica just wrote that. How do you feel about annual physicals?
Oh, there we go.
My 32-year-old husband, and I'm so mad because now we're running out of time and I haven't addressed it, but let me just.
Oh my God, she literally just wrote that.
Yeah, because we have like 7 minutes left, because this is actually really important. Annual physicals, okay? I'm going to make this as short as possible. A couple years ago, the government came out and said, you are not allowed to bill an annual physical anymore. You have to call it a preventive health assessment, okay?
Okay.
This is what it boils down to. An annual physical does not save lives, okay? Whether you go for an annual physical every 365 days a year or not, I don't care. What we care about, okay, is what happens at your physical, generally speaking. And I'll tell you, I have kept doing physicals because for my patients and for me, it's a reminder, you need to come in at least every 1.5 to 2 years for your screens. It's an insurance mechanism to make sure that you're not going, because if you ask somebody when was your last colonoscopy and they say 3 years ago, I guarantee you look in their chart, it was 10. Okay, we don't remember when we get these things done. So if you go to your family doctor every single year for your physical, are you going to live longer? Probably, you know, it's not that we're going to extend your life, but if you're not going every couple of years, are you going to be having your screens done? And that's why it's important. So for women, you need to make sure you're getting those screening tests done, your mammograms, your pap smears, okay, your colon cancer screening at a certain age. Okay, for men, you have to go. Men, it's a little bit less. Men don't have as many like screening issues as women do, right? Men still have to have their colonoscopies done. Prostate stuff is another kind of story, but generally speaking, yes, I do that. But it's not so much the annual physical that you need to do, it's your screening. And is your screening being done at the appropriate time intervals, okay? The other reason I like to do physicals every year to 2 years is because, like I said last week, I like to do skin exams on my patients, right? I like to check the back of their bodies for skins, for their, any moles and stuff that they can't see. It also allows me to talk to patients about new vaccines that have come out in the last year or two, if they don't know about them. And it allows me to just address any concerns that they have, right? If they've had any concerns in the last year to year and a half. But don't get so hung up on the fact that, oh my gosh, I haven't had a physical in a year. Okay, fine. Are your screening tests up to date? You know, if they are, then you call it whatever you want to call it. You can call it a physical, you can call it your annual health review. That's the bottom line, okay? So that's a good point. I had neglected to kind of talk about that. So yeah.
Well, I was just bringing it up because mostly because of the pap tests, right?
Yeah.
I know that they used to be done every year, right?
Yeah.
And now they're like every 3 years, I think.
Yes, every 3 years if it's normal.
Right, because so like I had a situation where it was abnormal, and then I actually had precancerous cells on my ovaries,
right?
That I had to actually get surgery done and all that stuff. So for me, it was great to because they caught it, right?
Yeah.
They caught it early because I had the pap test.
Because a pap test it's a cancer screen, right? We're screening for cervical cancer. That's all your pap is doing. It's not looking at your uterus. It's not looking at your ovaries. It's looking at your cervix. Do you have signs of cervical cancer? So it's a cancer prevention method.
Right. So they saw that my cells were mutating. So they caught it early. So they caught it, right? So what I'm saying is, I mean, for women now it's every 3 years, but you think that, you know, if you do it every 3 years as opposed to a year, you're still kind of catching it in time.
Yes.
If your pap test is, you know what I mean? It's kind of tricky.
Totally. I totally see that. And this came up a lot the first couple of years that we changed the screening interval. The reason it's every 3 years is because we know a lot more about HPV now, which is the virus that causes cancer of the cervix. And it's not a fast growing virus. It's aggressive. It gets into the cervix cells really quickly. But once it's there, it's kind of like colon cancer. It doesn't become cancer like overnight. It needs time to kind of have that effect on those cells. So if you have a normal pap, the chance that you're going to go from a normal pap to florid cervical cancer in 3 years is pretty unlikely. That being said, you know, patients can do them every year. You just have to pay for it out of pocket. Okay. So I have patients who are like, I want a pap every single year. I don't care. I say, okay, that's fine. There's a little box that we check on the pap test paper, and the patient will get billed for that. Once that pap test is abnormal, depending on the degree of the abnormality, because there's different abnormal levels, then that changes, right? Then you're going to be screened depending on what the abnormality is a lot more closely. Okay, screening changes after that. But that's why it changed to 3 years. It's because we know more about the virus now over the last several years that we've been researching it. Cool. Yeah. So just make sure you're getting your screens. Okay, guys?
Cool. Thanks, Doriana.
Hey, no problem. Have a good day, guys.
Thanks, guys.
Enjoy the weather.
Thanks, Doriana. Appreciate it.
Okay, ciao.
See you guys.
Bye.
Yeah.